Welcome to the Linking Research Policy and Practice Conference. This is already the fourth session of today, which happens in parallel to the third session in French that's happening right now for Burkina and Burundi. But you are joining the international session on maternal, menstrual, and child health. We have three presenters here today. As you can see in the screen, Femke, who will present on a global perspective to menstrual health, Putri, they will present on the Indonesian context, and Aminat, who will present on the Nigerian context. There will also be a discussant with us today, which is Pema Lhaki from Nepal, and I will explain a bit more about her role later. I also would like to thank Wendy Umlauf, my colleague from ShareNet International, is here with us today, who is doing the technical support. Yes, so if you have any questions, please feel free to reach out to us in the chat. And the chat can also be used to communicate among each other. And I would also like to welcome you to ask you to introduce yourself in the chat. Maybe tell us where you are joining us from, if you are part of an organization, what organization that is. But I think Wendy has already put some more questions about that in the chat. Yes, so as I also mentioned, there will be more sessions today. So Wendy also just put a link in the chat for the program of the entire day. So maybe if you feel inspired and still energetic after this session, feel free to still register for one of the sessions that will happen this afternoon or in the evening time if you are in Asia. Yes. So for the structure of today, we will start off with three presentations, as I said, by Femke, Putri, and Aminat, and they will each present for like 10 to 15 minutes. And after that, we will open the floor for questions and for a nice discussion. So as this event is called Linking Research, Policy and Practice, we also especially invite the people working for organizations and maybe in policy making to also share their experiences of how these research findings can be used in their organization, because I think also as a young person myself, it's always nice to hear how our research is used in policy making and practice. And after that, the session will close, and there will also be room to join the networking session, which is also explained in the overall program. So next up first is Putri Widi Saraswati. I hope I pronounce your name correctly. Putri is a public health professional and medical doctor with a specific expertise in SRHR and social justice. And after they worked as a general practitioner and really providing comprehensive SRHR services in outpatient basis in Java, Indonesia, they did their masters at KIT Royal Tropical Institute and the Vrije Universiteit Amsterdam. And during this master's program, they researched how Indonesian national public policies address maternal mortality from the perspectives of health equity and intersectionality. And this is also what Putri will be presenting about today. Putri, you yourself really call yourself an advocate for SRHR, gender equity, and social justice. And on your profile, I also saw that you aspire to work on public health issues related to marginalized communities and people living in low resource settings. As I mentioned, there will also be a networking session afterwards. So if you have kind of common interests, also make sure to catch Putri there. Thanks a lot, Putri, for being here and presenting, and the floor is yours.
Thank you, Charlotte, for the opportunity. And should I share my own screen or? Okay,
yes.
Let me do that. Okay, I hope you guys can all see this. So hi, everyone. Thank you for the nice opportunity to talk about what I did as a master's thesis just about maybe 2 months ago, because I just recently graduated. And also it's a good opportunity to actually tell you a story about my home country, Indonesia, what's happening there, what our policies doing, what kind of problems we are having right now. So it's nice to share that. Like Charlotte has introduced before, my thesis is surrounding the public policies, our national public policies in Indonesia, and how it addresses the issue of maternal mortality or maternal deaths. And I'm looking at it from two perspectives, health equity and intersectionality. Sorry, it's a bit, okay. And this is just a little about me. My pronouns are she, they, like Charlotte mentioned. I'm graduating from KIT, and I've been advocating for SRSR and gender since 2014. I chose this topic for my research because of the problem that we are still facing back home. So our maternal mortality rate is quite high. In 2015, it was 305 per 100,000 live births, which is actually the highest in the region in Southeast Asia. And this is not an equal burden as well between different groups. For example, if we look into the maternal mortality in Eastern Indonesia, such as Maluku and Papua, comparing to maternal mortality in Java and Sumatra, is actually twice the rate. So they are, like women in girls and Maluku and Papua, they are twice as vulnerable as women in Java and Sumatra in terms of experiencing maternal deaths. And despite the efforts of our government since maybe a decade to actually prioritize in lowering the maternal mortality rate, first, the number is still high, but also there are still gaps and inconsistencies that's been the source of criticism in and between public policies. So in the, for example, the health policy sector itself, but also inconsistencies between different policy sectors. That's the background problem. And because of that, I look into 4 objectives in this research. First, I would look into whether our policy actually integrate the concept of sexual rights and reproductive rights in the policy itself. The second one is to look whether our policy actually integrate the different intersecting social determinants of health relating to maternal deaths in the policy. The third one is to look into what other LMIC, lower middle income countries, is doing in terms of lowering their NMR and look into what we can learn from them. And the fourth one is to derive recommendations for our policymakers regarding how to best lowering maternal mortality and protecting women and girls. And this is an analytical framework that I do. And for short, in the middle, you can see different intersecting determinants of health with gender as an entry point. And on the outer layer, you can always see different policy sectors that are looked into. More details, I can explain it later if somebody is interested. And this is a qualitative method. I mainly look into our national public policy documents. I also did key informant interviews with individuals, professionals working in the space of SRSR policy. And I also do some literature review as well. For the findings, I will divide it in 4 different sections according to the objectives. First, I look into the sexual rights. So I found that the term sexual rights itself is rarely mentioned in the policy documents. It's almost, I would say, it's almost non-existent. And there is also focus on negative emphasis when the policy document is talking about the term sex. Usually it's related to certain moral perceptions. And then when we look into the rights itself, because for example, like a regulation and policy is supposed to protect rights, the rights is there, but they are constrained within morally and religiously acceptable contexts. For example, we have regulations that states certain kind of health services related to reproductive health are only accessible to those that are legally married. And just like an information in our country, if you want to be legally married, your marriage has to be approved religiously first, and then the state would kind of like legally accept it. And it also really surrounds the concept of heteronormativity, because a lot of concepts of legal relationship in our policy documents is always between a man and a woman. And there are attempts in the policy documents for rights promotion, but the attempts are non-binding. It doesn't really have legal consequences, for example, or it doesn't really, it's not obligatory for practitioners, for example, to follow We found some guidelines regarding sexuality education at school, but it's just like the guideline was just there, but there are no enforcement to actually apply it, for example. And the second part is about reproductive rights. The term reproductive rights itself is mentioned more often than sexual rights, but still the right itself is constrained within morally and religiously acceptable context. For example, when we talk about the classic issue of abortion, the safe abortion, the requirements, we do have some rooms for abortion policy for giving safe abortion services to people, but it's really constrained between certain framework of, I would say, more like morally acceptable framework. And there is also a stronger emphasis on population control compared to emphasis for women and girls as individual right holders. For example, there are wordings in the policy documents that place women more like as a tool, so to speak, to make a better future generation. That's why they have to have good maternal health. But it's not really emphasized that women themselves as individuals, as right holders for not dying, for example. And then the third part is when we look into intersecting determinants of health. I looked into several and I found that some are addressed, but superficially, or they are addressed fragmentedly between sectors. Is there incoherency or incongruency between policy sectors? For example, for determinants such as gender, age, economic status, occupation, geography, education, SIV, COVID-19. For example, in one side, there are policy documents that actually emphasize gender equity, but in other policy sectors, it's the other way around. And there are some determinants that only vaguely address or not at all, such as race, social status, mental health, obesity, and disability. And some are even used to put barriers instead of to reduce barriers. Like I explained before, determinants such as religion, sexuality, and marital status are used to actually put barriers to services. And when we look into what other LMIs do to improve their maternal health and decrease maternal mortality, we can learn some lessons. For example, in policy that is pro-marginalized groups. In Thailand, for example, they have this pro-rural policy, and the access to maternal health care is part of their rural development policy. And it's also interesting because in Thailand, they developed this pro-rural policy in many different sectors parallelly. It's not just health, they also invest in sectors such as education, economic empowerment, infrastructure, etc., to actually make the rural area develops as a whole. This is also a lesson that synchronizing between sectors is important. And we also learned that an evidence-informed policy is really important. When we look into, for example, the policy from the Kerala state of India, they have a feedback mechanism, when they do an audit of maternal deaths, and then they use the result of that audit to actually inform the policy to make sure that the standard of practice for maternal health care is actually of good quality. And they are the first state in India who actually applies this kind of feedback mechanism. And we also see that through Nepal's history when they legalized their abortion policy back in the early 2000s. This is very interesting because when people were advocating for liberalization of abortion policy, they have a big amount, good quality of data that shows that unsafe abortion actually caused deaths. And that is one of the resources that they use to push for better regulation for safe abortion care in the country. And Nepal also showed that there are strong and continuous political commitment, even for non-political feasible policies such as abortion. And from that findings, I would like to give 4 recommendations, and they are given to the national government of Indonesia, my government. The first one is to fully integrate sexual and reproductive rights into policies. As the findings show, there are gaps in how our policy are protecting the rights of the people. There are certain groups that are not protected. There are certain groups that actually have more barriers introduced by the policy itself or strengthened by the policy itself to access services. And the second one is to strengthen gender mainstreaming in and put women and girls at the center of policies. We should not focus on population control anymore. Maybe it's not literally, it's not emphasized in that language, but when, for example, you find wordings in policy that put better population and better future generation on top of the women themselves, is already suspicious that the policy is not really on behalf of the women as individuals, which is right holders. And the third one is to generate better evidence to inform policies. When compared to Nepal, for example, we are lacking a lot of data regarding unsafe abortion. Data shows that we have problems with unsafe abortion, but when I try to find local data regarding it, for example, government's data, is really hard to find it. And this is critical because when you develop policies based on certain biases or moral principles, but not on evidence itself, it's gonna make your policies skewed. And the fourth one is to involve and synchronize between policy sectors to actually co-synchronize investment in different sectors, which actually influence health, because we know that health is a cross-cutting issue. And making a policy in the health sector, only in health sector, would not solve health problems such as maternal mortality. And this is just a note that if I was asked what I will prioritize, because, for example, we cannot do everything at the same time, I would say that the two most important recommendations or maybe approach that could be done in our policy sectors regarding maternal mortality is to push for better gender-related sensitization and competency building for policymakers. One of the interesting things is that we do have some regulation for gender mainstreaming in the policy, but it seems like this regulation are just written on paper. The policymakers themselves are not sensitized enough to actually introduce a truly gender mainstreaming approach in the policy making. And the second one is to conduct research using public-private partnership. Because, for example, we have a lot of community organizations, CSOs, NGOs, the community themselves, root-based organizations that is knowledgeable regarding what is happening at the root level, at the regional level. And tapping into the resources of the private sectors would be really resourceful for our government to develop policy that's relatable to the people itself. I think that's what I can share today, because I really want us to have better policies to save more lives, because our women don't deserve to die. I think that's all, and thank you for the opportunity.
Thanks, Putri, a lot, and strong message at the end also. Please feel free to keep putting your questions for Putri in the chat, and we will take them after the third presentation, because last but not least today, Aminat Salami will present her research to us. And Aminat holds a master's degree of public health from the University of Ibadan, Nigeria, and currently works as a youth innovation officer for the Society for Family Health Nigeria. In 2019, she was nominated for the 120 under 40 list. That's an initiative by the Bill and Melinda Gates Institute for Population and Reproductive Health that each year really recognizes and highlights the achievements of young family planning leaders worldwide. This will also not be the only session in which Aminat will be presenting. So if you're really excited after her presentation, great to see that your camera can be turned on. Please make sure also to attend session 6 today, so right after lunch, European time, since you can listen to another presentation from Aminat then. But first in this session, Aminat will present about complementary feeding practices among mothers of children aged 6 to 24 months in Ibadan. Aminat, take it away. I think.
Thank you. I would like you to share the screen.
Yes.
Okay.
You want to do that yourself, or do you want Wendy to help out?
Wendy should please help out. Thank you.
Yes, thanks, Wendy.
Okay. Okay, can I start now? I think it's here. Okay.
Yes, please go ahead.
All right, thank you. Hi, everyone. I'm Aminat Salami. I'm a graduate of Institute of Child and Adolescent Health, Faculty of Public Health, University of Ibadan, Nigeria. The title of my presentation is Complementary Feeding Practices Among Mothers of Children aged 6 to 24 months in Ibadan. Over the years, the Nigerian Demographic Health Survey has shown that 29% of children are under 5 are underweight, 18% are wasted, and 37% are stunted. It's also obvious that poor feeding related to undernutrition and malnutrition is rampant, leading to child mortality, and eventually maternal mortality. The current practices of timely introduction of complementary feeding in Ibadan are not known as at the time of this research. The research on complementary feeding is necessary to make the gains of exclusive breastfeeding worth the while. We've been hearing so far that, okay, exclusive breastfeeding for 6 months is the best for babies to make them develop well cognitively, physically, and all because of their immune system, to make sure that they are vibrant, and also to make sure that they are active and not visiting the hospitals here and there. So for an exclusive breastfeeding to be effectively seen, that, okay, this is actually the effects of this feeding, the complementary feeding after 6 months should actually be employed. So this study is to identify the patterns of complementary feeding in mothers of children in 6 to 24 months in Ibadan. The methodology employed involved 441 mother to child peers through a cross-sectional study around the 10 randomly selected health facilities in the communities close to them. So there are social demographic factors such as their age, the parity, the feeding methods, the timely introduction of the complementary feedings were all obtained through an interviewer administered questionnaire. It was observed from the results that only 34.2% of these children aged 6 to 24 months were fed in accordance with the recommendation of infant and young child feeding practices. So less than a quarter of them introduced foods less than 3 months of age, or from 3 months and above. Meanwhile, we had majority of them introducing drinks and food between the age of 4 to 5 months. So it was observed that the mother's education, age, information about complementary feeding, the parity, that is the number of children they have, where they are living, showed a statistically significant difference. It means that they have a very high effect on the introduction of complementary feeding to these children. Meanwhile, the income, the marital status, gender did not really show an effect. So it means that a mother's age depends on how old and how knowledgeable, how literate a mother is. That's when she'll know that, okay, this is actually the right time for me to introduce complementary feeding to my child. Also here in the South, because here we are in the South, there is influence of the mother-in-law, whereby the mother-in-law of the mother can say that, okay, it is time for you to introduce complementary feeding to your child as at 3 months. Meanwhile, she's still supposed to be on breastfeeding. So if they have the information from this antenatal care visits, that's where they can easily get, okay, from media, from their enabling environments, that's where they can easily get the fact that, okay, this is not the right time until after 6 months. So conclusively, mothers introduce complementary foods earlier than recommended. Then widespread information, education, communication, and behavioral change communication activities on initiation of complementary feeding should be implemented in maternal and child health unit of the hospital. Like I said earlier, our visits to the hospitals, be it antenatal, postnatal, or for any other activities, there should be all this information, widespread information and education. It can be on posters, it can be on flyers in the hospital. Just read it out. Okay, complementary feeding at 6 months. introduce this at this particular age. This is what you practice with your children. Hygiene, safety, and all. So from this, we'll be able to minimize the rate of child mortality. Thank you for listening.
Yes. Thanks a lot, Aminat. Yeah, I'm really happy to go into the discussion, and I also already have some questions myself, but I will wait a little bit and also give the room to other people. And I especially find it interesting that all three presentations kind of highlight that we should not only look at these things from solely a health perspective, because also culture and equity play such a big role. So I hope to hear a little bit more about that later. Yes, and also please feel free to keep putting your questions in the chat, and later on you can also work with the raise hand function if you have a question. But before we dive into this plenary discussion about the presentations, I would like to give the floor to Pema Lhaki, who is the Executive Director of NFCC, a non-governmental and non-profit organization providing and enhancing reproductive health services in Nepal. And their mission is to really ensure accessible, available, and affordable reproductive health for all. And they also closely work with the government of Nepal. So I hope that Pema can also give us some insights of how research is used in policy making and practice.
Hi. Okay. Should I put my video on?
If it's possible, I think it would be nice that we can see you.
I think my Zoom is going to close if I put my video on.
Okay.
So.
Your sound is great, so we'll leave it with that then.
Okay. Thank you for having me here. And it's amazing to hear the three young researchers and to hear what they had to say. Just we at NFCC, the organization I work at, we really believe that research is important. We believe because it helps build evidence, and evidence helps us advocate with the appropriate authorities. So at least at NFCC, we really believe in the power of research. Before I get into my comments on the three presentations, I also want to say that while I want to thank you guys for giving me this platform, I also want to inform you that somebody I really look up to in the sexual and reproductive health arena in Nepal is actually a guest here. So I feel like quite, I don't know, in Nepali we say quite small, trying to act big speaking because he is the expert and he's like my guru who I keep running to for every advice and everything. His name is Dr. Rajendra Bhadra and he's here. And I want to thank him for coming. And I don't know, somehow you got the link, but I really appreciate Dr. Bhadra for coming. And I just want to let you know that I'm maybe 1/4 of all the things he has done and advocated for in the field of reproductive health in Nepal. So yeah. And he's also actually been very closely associated with NFCC and has done a lot of work with NFCC, even prior to me joining NFCC, like in the past 34 years. So, okay, thank you for coming, Dr. Bhadra. And so coming back, I feel like our background of our organization is reproductive health. We work a lot on research. After I joined NFCC, one of the major things that we really focused on was establishing the M&E unit because we felt that it was important to do research. And while I am not from the public health background, I am a sociologist, I believe that that plays a very, very big role, understanding social systems, because it helps you, sort of understand how certain things, what will be the uptake and acceptability. So the research that was presented is very interesting. I feel equipped to actually comment more on the one which is to do with menstruation. The others, I don't feel I have enough of expertise or experience. I've worked in those, but I'm not in that position to be able to give good advice on that or feedback. With regard to menstruation, yes, we have worked a lot on menstruation, and the organization has worked. I have worked. I am really happy to hear this, and really happy to see that this was, sort of researched by Femke. I'm sorry if I got your name wrong. This is something, I mean, there's some people here, I think Alethea is also here. There's some people who know me, and this is something that I really believe in, the fact that sometimes the whole context of menstruation may become so dictated. Hello, can you hear me? Hello, can you hear me?
Yes.
Okay. It may become so dictated by people who are bringing in the funds that we just forget, we really forget about the people we work for. And so it's interesting that that you mention it, something that I have been speaking about for quite a long time. I don't know how many people are listening. Obviously not enough people are listening to me, or I'm probably not speaking in the right platforms, because organizations still continue to come and distribute sanitary disposable pads without really understanding context and without respecting the fact that something which is become like the very retro thing in the West to use reusable and cloth is something that Nepali women have done forever. And every time an organization goes into the villages of Nepal and tells them, what are you using? And then they say cloth, and instead of making them feel good about the fact that they are using cloth, and maybe the point is how you use it better, right? You can use a cloth, I mean, but just use it correctly and in a proper way, and manage it a proper way. Most of them go and say, yeah, cloth is not good. You'll get this infection, that infection. This is going to happen. Maybe you need to use disposable napkins. And so much so that the Nepal government has also made a commitment to distribute disposable sanitary pads. And all of that is such a concern for organizations like us who really believe in something that we call the right to self-determination. And the right to self-determination, not in terms of there's something which has got a very political leaning to it, but we are talking about the right to self-determination that every menstruator should have. It should, like every Nepali menstruator has the right to determine by herself that I want to use cloth and I'm happy with it. And we need to, as development professionals, need to provide the space for her to feel, quote unquote, empowered by the fact that that is her decision. And she made that decision understanding her reality, right? So I think when we don't do that, yes, we stigmatize menstruation more, because a woman or a menstruator who uses cloth is not going to openly speak about what she is using, because she knows that the person she's talking to or speaking with is actually come with a packet of disposable napkins. So I think I really like the topic, because I feel like it is time for a lot of NGOs, and I can't speak on behalf of other countries, but I definitely know on behalf of Nepal, I can speak that they really need to look back into what they're doing and really see that, am I going the right way? And case to note, which is a bringing together of the other presentation that was just given about the breastfeeding and the complementary feeding. And see, there's another thing which I'm just going to give you an example of. So Nepal is a country where women don't have a problem breastfeeding, and breastfeeding in public is not a big deal too. I breastfed my son until he was 3, and I was very proud of it. In fact, I tried to see who's going to beat my record, But unfortunately, recently, I was shocked to hear that there's going to be a new commitment where they are going to build breastfeeding rooms in some places. And I found that such a Western agenda, And I did speak to some people about it, but I was like, why are we going there? The West, they are trying to normalize breastfeeding in public. We breastfeed in public, but just because somebody and some NGO came and said, oh no, you need to get a room and women can go there and breastfeed, you are stigmatizing breastfeeding. So, organizations and NGOs really need to think, when they come to Nepal, and I say when they come to Nepal because I can speak on behalf of Nepal, I can't speak on behalf of others. I mean, come on, you are coming to Nepal and saying that you need a room where you go there and breastfeed. If I can breastfeed in public and I'm okay with it, why are you creating that doubt in my mind that I have to go to a room to breastfeed my child? That is the way they start the first step of sexualizing breastfeeding. Nobody looks at a breastfeeding woman in Nepal in a sexual way, at least till date, and to my knowledge. Or at least nobody looked at me in a sexual way, I feel, yeah. But, you know, it's crazy. And so I think you can draw parallels there. You know, same thing like they're coming and pushing all these different products, you know, and I recently commented on the new book called Period. I have a problem with the word period because it's such a word that is only used by the English-speaking countries, and we used to say menstruation, which is technically the science term for it. But now we all have to say period because a few of the English-speaking countries said it. That is marginalizing me, right? I speak English, but most of my country people don't, right? So those are the things that I think international activists also need to consider. And lastly, recently I commented on a book which is written called Period, End of Sentence, and it was based on the Oscar-winning film by the same name. And it was so funny because, again, building on what Femke said, the book talks a lot about the movie that was made earlier, a book which was written earlier called The Red Tent. And they have romanticized the whole concept about menstruators and going to a tent and sitting and, you know, talking and this and that, while we here are advocating for the abolishing of chaupadi, which is menstrual isolation, because menstruators are dying in huts. And this is only, chaupadi does not represent the whole of Nepal, firstly, right? It is only the far west and midwest of Nepal. Yet it has become the stereotype by which all Nepali menstruators are judged. And then to one step further is, while in the West, you know, there is a red tent and everybody goes there, and it's such a powerful and beautiful way to celebrate menstruation and the power in menstruation, the same headlines will write the news that, oh, certain and certain women in far west Nepal sat in a chaupadi hut and they died, and oh my God, it's so bad in Nepal and all of that. So I think before those headlines are written, we need to really look at what we are doing and how there is so much of hypocrisy in that. You know, there's a saying, people in glass houses shouldn't throw stones, they should look at themselves. We can say, okay, to you know, sort of doing things like red tent, but I'm not saying chaupadi is good by any means. Of course, we work that it is, it is a woman to decide, a menstruator to decide what they want to do. Definitely we need to equip her with the information for her to make a decision. I'm sure if she was in that situation where she had the decision-making power, the ability to negotiate, I'm sure she would not want to sleep outside for 5 days in a hut. So we can't say that she's doing it on her own accord. So there are a lot of variables there. However, we can't celebrate red tent as something so nice and then, you know, really say, oh my God, Nepali people, they stay in tents. So yeah, I want to end by saying that I really, really applaud the 3 papers. I think what hit me the most was the paper on menstruation because it's so close to my heart. And I really want to thank Femke for being a Westerner and looking at something that we have been trying to advocate for at NFCC, and I have been trying to do so too. Thank you so much, and that's it.
Yeah, thanks a lot, Pema. Femke, would you like to respond?
Yeah, I just want to say thank you, and I completely agree with how you describe the discrepancies between views on menstruation and breastfeeding. So yeah, thank you.
Yeah, thanks a lot. Yeah, and also indeed, welcome to Dr. Padra. I hope I pronounced it correctly. I mean, Pema, if it's for you already a riddle, how you got the link.
Thank you very much.
Do you want to comment also?
Not at the moment, I'm just listening. And you're doing great, so thank you.
Great to have you here. Yes. Yeah, actually, if it's okay, I would like to ask a question myself and then also open up the floor to all the other participants. Yeah, Femke really mentioned in her presentation that menstrual health should not only be looked at from an SRHR perspective, but also from outside of a health perspective. And I also kind of heard that come back a bit in Putri's presentation, also in Aminat's presentation. So my question is a little bit, yeah, maybe it's a bit a difficult question, like how do you agree that we should also look, for example, at maternal mortality from outside an SRHR perspective? Because Putri, you were making a very strong point that actually SRHR should be more integrated into these policies, and how we could actually, yeah, do that.
That would be for me or for
Yes.
everyone? Okay.
Yeah,
sorry,
also for the others, but
okay.
in the first place for you.
Yeah. So, for example, like one of my fund when I scan the policy documents, I try to find if any other policy sectors outside of health is actually being aware of, let's say, things that's influencing our maternal mortality. And for example, because maternal mortality is really highly prioritized in our policy for the last decade. It's literally on top of the list of things we should do in the last decade. And we've been doing it for 10 years and it's still not going down. So when I look into, for example, sectors like infrastructure or I'm not sure how to call it, more like something like rural development, it's surprising to me to see that they don't mention it as part of the part of their, as a like at least as an acknowledgement. But we also know that maternal mortality is really related, among other things, to infrastructure, like for example, roads, streets, and a lot of other things that actually make some people can access health facilities. So maybe we could also say that, in general, they also care about it more in the health access sector, not in maternal mortality perspective only. But it's still surprising to me that they don't recognize it as a problem, to say that it's really prioritized in the national policy developments. And it's also really saddening to me to see that, for example, in sectors such as the Ministry of Religion, some perspective in the Ministry of Social Affairs, there's actually propagating stigma against things that related to maternal mortality. It also seems that policymakers don't really realize that, for example, if you stigmatize sexuality education at school, or if you stigmatize access to, or if you stigmatize pregnancy as out of marital bond, legal marital bond, it could actually influence access to care for pregnant people. It seems like policymakers are not aware of this connection. They always, when we talk about maternal mortality, it's always about, how the context is always about like married women, to be honest, like how they could access services. Yes, it's important, but then you keep missing groups that is not seen because you keep using this framework that's excluding people. So that's why I think maternal mortality and SRHR in general should be a cross-cutting issue, because other sectors should be aware of that and should be aware of the fact that what they're doing in their sectors is actually influencing people's health and well-being. That's for me, yeah.
Yeah, thanks a lot, Putri, for these insights. And I think that also links again a little bit to your question that you had to Aminat herself before.
Yes.
So maybe, do you want to ask the questions again, and then for the others to hear? And
yeah, so maybe it's just a sharing from my side when I do some literature review regarding, for example, for my side, it's the other way around. So from Aminat's research, it's more about like kind of like feeding not at the right time. But in my literature review, I found that pregnant women are not prioritized to get the right nutrition in the family because of gender dynamic. Because, for example, in the family, the father is always prioritized, the father and the children, especially male children, is prioritized to get like the best of the food. So usually the mother, even though she's pregnant, she will eat the least, or she would eat like just the rest of the food. And for example, if we look into researches, it's really a lot of them are focusing on like knowledge of the mothers for nutrition, for example. And then it triggers a question in my head, like, for example, how actually being a woman in a certain type of society with a gender dynamic influence, how women can be knowledgeable And when, for example, we look into health interventions, usually they target behavioral change, right? They target like knowledge and behavior perspective of individuals. But I think, especially in my country, I would say that it's lacking perspective that address determinants that work on the more structural level. Like giving knowledge to women might not be enough. There is some things related to how they behave that actually is more on the structural level. For example, this gender problem, they cannot deal with it themselves. It's not about knowledge, it's about power, for example. So yeah, I just wondering if it, I mean, as recent this also came up as one of her findings. So it will be interesting, yeah.
Thank you. Aminat, would you like to respond to that? You're muted. Don't know if you're still here, I hope. No. Maybe also from the other participants, because yeah, well, I assume you all joined this session because the 3 topics were interesting to you, and I think also in the 3 topics, like again, this determinant of culture and also family involvement comes in. So, are there any questions or maybe comments also from your field of work that you would like to share? Doreen, you raise your hand. Please go ahead.
Yeah, if there are other questions, I can also wait a bit. I'm recovering from COVID and I don't feel extremely well, so I don't put on my camera. But I wanted to speak a bit. And first of all, I wanted to thank all the 3 presenters. It was very enjoyable to listen, and also amazingly, I recognize a lot of what you are saying. It's all topics that I've been involved with or working on. So it is very nice to hear what you're saying. I wanted to say a little bit about what we are discussing just now, but I also wanted to go back to especially Putri's presentation. And I think those who know me well know also that I have a bit of a special relationship with Indonesia. My children hold Indonesian passports, and my first one was born in Indonesia. And I realized that I have been there in a very, very privileged position. And that only makes me very interested in the theme of maternal health, and all the recommendations that I hear, I couldn't agree with more. But I'm also thinking these are recommendations that we heard also earlier, and what can we then do to bring it really to a next level? And maybe the same matters also to the recommendations of the presentations of the other speakers. And that is also, I think, what SN-INT can do to really link the researchers, you, with the implementers and the policymakers. So when I was hearing about this priority recommendation of Putri about the gender sensitization training, perhaps for policymakers, I'm immediately thinking then, okay, who then? Which policymakers? And who would fund that? Obviously, it's not on their agenda and in their budget themselves. And if I hear about like public-private partnerships, maybe to support in research, which public-private partnerships could we potentially think of? So those are my more than critical questions, but I also don't think the answers are right there. Maybe this is something that we can think about together. I assume now in this group there is not really like a policymaker from Indonesia, but maybe we know them, maybe we know the implementers, the people who make the programs. I think regarding Femke's presentation, we do know which organizations are working on menstrual health. You've been talking likely with quite a few for your research. So yeah, how can we make sure those recommendations are actually being listened to and taken up. Yeah, that is really what's now going on in my mind. There was one other thing, and that relates maybe to what Charlotte was also hinting to, like this intersectionality or the wider context, or to take these issues also beyond the SRHR sector. And I think what comes back, and also what I learned over the past years working on SRHR, is that this social cultural construct around like, you could say power, but I think more specifically, it's about self-determination. And also in the more recent years, I learned about, it's more also to do with autonomy and the right to decide over your own body. This is something that makes it so difficult to change or to move forward. So I think if we talk about maternal health, that being very high on the agenda of the Indonesian government for years already, but those maternal mortality rates, they don't decrease much more. They've decreased, but then they get stuck. This maybe hasn't to do with not putting the issue high on the agenda and putting so many efforts in improving, services and systems and information and whatsoever, but it really has to do with the fact that still in the social cultural context, the right of a woman and her power to decide over her own body hardly exists. And that is also what you read back in all those policies. No word about rights, no word about sexuality, and still putting a population reasons higher than individual rights. So I think there is still something that I think comes out also from the other presentations a bit, that we can think of or should discuss more, and maybe also try to bring up or bring out in research. So this is what I wanted to say. I don't know, Putri, maybe you want to say if you have thought about which policymakers should be targeted and how to get them. But I'm very happy also to discuss it at any other moment. And then I've said already way too much, I think, Charlotte.
I think you made very valuable comments. I will leave it to Putri to respond.
Yes, it's actually true what Darren is saying. That's one of the things that's one of the challenges that I found in actually applying these recommendations, because it's always easy to write things down, but it's not always easy to apply them, right? So one of the things that I also found during my research was that there's a disconnectedness between, for example, people who works on gender. Usually, typically, there are social scientists, for example, social activists, and people who work in health. There's a big gap between them. So it's really a challenge for us to actually connect them, because we know that gender and health is unseparated. I mean, it's really important to connect them. So that's one of our homework. And for example, our healthcare providers, we are not sensitized on gender as well. And when we do, usually we learn it by ourselves. So it's not something that in the system, the education system, for example. And then one of the things is also that we do have regulations for gender mainstreaming policy. It's been existing since 2000. And at the moment, there are some ministries, not all, some ministries that have their own regulations in introducing gender mainstreaming in policy making, and also in, I think it's I'm not sure, I think it's budgeting as well. But so there are progress, but the problem is also about really sensitizing the people who are there in the ministry, for example. And when I talked to one of my resource person, they mentioned that, interestingly, this is still a challenge, but for example, if you look into public servants that are like the younger generation, they are more sensitized to it, they are more aware of it, and in their own ways, they try to advocate for it. Maybe because of the power relation, they could not really influence a lot of things when they are not the boss yet, but they do things to actually try to make things better. So yeah, maybe there will be some hope, but it needs a long-term investment. And when we talk about sexual rights, for example, I have to admit that it's really hard to talk about sexuality and sexual rights in my country because the word itself is already stigmatized. So I think Doreen is right that we need to address that, but the question is how to address that in a way that's acceptable. Not just acceptable. I don't really hate the word accept. I don't really like the word acceptable. More like something that would work in a way that we could do our advocacy, and the advocacy could work in a way that people would actually accept our suggestion, for example. So maybe it could also involve based on evidence, for example. So we don't just advocate things based on, for example, so to speak, ideology, because even when we talk about feminism in my country, sometimes it's always stigmatized as well. So there are efforts from, for example, women religious scholars to mainstream gender equality in the religious sector. Maybe we could also work with them, but we need also to be careful because we also know that gender biases is rampant in the sector as well. So I don't really have an answer to that, but yeah, I know that Doreen's question is valid and is a very valid challenges in trying to make our policy better. But I still see that, yeah, I mean, things are changing in the newer generation, hopefully. Yeah.
Thanks, Putri. Femke, do you like to add something or highlight it from a different perspective?
Yeah, I wanted to also come back to what Doreen said about how to bring in organizations, how to get them to listen, so that maybe kind of adds to Putri's point. But it is a different topic, so I don't know if you have comments or questions you want to ask first, or
no, please go ahead.
Okay. Yeah, I think platforms like this already are like a really good start to bring in organizations and to like get them to listen. And for menstrual health specifically, interventions in menstrual health increased like really fast. I think in 2010 there were none. In 2020 there were 600, I don't know, something initiatives. So this outstripped the pace and funding of research necessary to inform the interventions. And I think that's a good way to start, because now the evidence base is increasing that some of the interventions are not sustainable, or things that are implemented are not used anymore. So there is momentum for change, I think. And I also notice in, for instance, what you said, I'm doing an internship now at Simavi, who is also working on menstrual health. There's a lot of momentum. People within organizations want to change it, but funding strictures are also limited, and they limit new ways of thinking about menstrual health. So I think that's a good place to start with advocating. And this also relates to how we can use, or I in this can use my position from the Netherlands to influence policy and funding, because as Pema just said, my role is not to come in to go to Nepal, for instance, and say how they should do their menstruation or how they should breastfeed, but we can influence funding structures, and especially Dutch policy in my case. So yeah, and that also relates to a question that was asked previously in the chat about the global menstrual hubs and menstrual networks, if those would be enough to cover one of my recommendations, which was to create a global network representative of all menstruators. And if I was planning to initiate or lead this network, well, for the last question, no, because I think that should not be me. We should like facilitate it. And also, for instance, the Menstrual Health Hub is a really nice network, but it is not representative of all menstruators. It originated from the WASH field as well, in line with how menstrual health appeared on the development agenda. So if we would use those hubs, we should restructure them, I think, with menstruators from Global South in the lead.
Yeah, thank you, Femke, and great to hear like your ambitions for the future to really contribute to this. And I cannot agree more than that there is always a momentum to advocate for certain things. So I think, yeah, that's a good reminder to all of us to be aware of these situations, be aware of these spaces where we can advocate more. And that's also what, of course, as ShareNet International, we are trying to do, to jump into these spaces and to through our members make all this evidence available to policymakers and practice. We are running a little bit over time, so unfortunately we are moving towards the end of our session. So to close the discussion, I would just like to ask Pema whether she has some last observations or conclusions to share based on the discussion that we have had. If not, that's also okay. If I don't hear you, then I assume it will be okay. Yeah, so as I said, no comments, great, thanks, Pema. Yeah, so unfortunately, our time for this session is already up. But as I said in the beginning, the good news is that you can really continue talking to each other in the online networking event that is now open. I just received a message from Hannah that the session in parallel to this one is also running a little bit late. So if you join, feel free to first have like a break of 5 or 10 minutes before you join, so that everybody will be there kind of at the same time. I think, yeah, Wendy has shared some details in the chat on how you can join this online networking event. And it's really nice to join because you can move from one table to the other and actually talk to people that are at the same table as you. Yeah, it's online, but still the best, I think, available to do some online networking. And furthermore, you can still sign up for some of the other sessions today. Wendy also shared the link in the chat again. And then with that said, I would like to thank all the presenters again, Femke, Putri, Aminat, and of course also Pema for being the discussant, and all the other participants for your questions. And of course, Wendy, thank you for all the tech support. So thank you all. And with that, I would like to close the session and wish you all a very nice day.